So I think MDS is also moving forward in a similar way to AML. Venetoclax, as I've mentioned before, in the AML setting, there's a lot of data now demonstrating its efficacy, and it's become a regular, it's part of the backbone of treatment for patients with AML. And there's now data from early phase studies of combining Venetoclax and Azacitidine for high-risk MDS patients, and it's showing significant efficacy. So I think we will see more and more data coming out about the use of combining Venetoclax with Azacitidine in high-risk MDS. Again, the immune therapies are also showing promise in this arena. So we have data with Magrolimab, which showed an overall response rate in combination with Azacitidine of more than 90% in patients with high-risk MDS. And what was particularly interesting in that earlier phase study was that those patients with the traditionally poor risk mutational profile were responding to this combination of treatments, which is just fantastic, because across the board, MDS and AML, where we're really struggling is those patients who have poor risk mutational profile. So being able to study drugs that might have efficacy in those particular diseases is really where we need to progress, because I think in some ways for those patients, for example, with lower risk AML, who we have perhaps an opportunity to de-intensify treatment in those patients who we can't get to remission or can't get to transplant. The goal of therapy now and the goal of research going forwards is to really use these novel agents and obviously emerging treatments in sensible, rational combinations, such that we can get those patients ultimately to transplant. Because when we consider that with high-risk MDS, there is no long-term cure, the goal of treatment is to get them to transplant. And doing that in the most effective way with the reduced amount of toxicity is really the approach that we should be adopting.